So this is a case that we're going to review with it's a female patient, about 68 years old. Implant was placed about 3 years ago in 2022, area of number 3, and patient referred to our office. And when the general dentist sent us an X-ray back then, that the implant was placed and restored. And when the patient comes in, we took another X-ray, and when we comparing those photos, I mean X-rays, in 3 years apart. As you can see here on the X-ray, this is 2022. You see the bone level on implant number 4, between 4 and 3. The bone level is here. And then this is 2025. You see the bone drop down almost to the third thread of implant number 3. So there are some pocketing there, some bleeding there, and so we're discussing the options for the patient. What I do, I always make it draw for the patient. It's easier to explain over the photos or X-ray to what we're gonna do, what's the plan is, till to explain it without any photos or X-rays or pictures. So my explanation was at one point the bone was about here, which is in this, you can see it here, and now we have about 30% bone loss between those two implants, which is not good. So anytime that we have a bone deterioration, anytime the bone is gone, the normal routine work is to doing bone grafting. So with the bone grafting, we want to generate bone. But the challenges that we have here, it's the area, interproximal area between two implants. So we have two titanium and the bone, and then we are trying to do the bone graft. So the question is the bone gonna generate there? It's if we're using the allograft or we're using the donor tissue from bank, it's a dead bone. If we put a dead bone between the area of two implants, two titanium, two metal, we are capable of generating bone there? I mean, is the dead bone grows over the metal? I mean, that's a kind of a very simple physiological sort of a question. So it's not possible with that scenario that we have here. It's almost impossible to generate the bone. All right. So patient has bone loss, patient has bleeding in between those two implants, and we know the peri-implantitis is it's a nightmare. We discussed that peri-implantitis cases on the previous of the YouTube videos. So the prognosis of the bone regeneration around the implants are not very high. So what is the next course of action? So the best one is doing the gum grafting. If we build up the keratinized tissue, at least we can preserve the rest of the bone. We can stop the bone loss, and we can give the patient some access for cleaning and oral hygiene. So the next photo we're going to bring up is the intraoral photo. So we're going to bring it here. So this is the photo that we took from the patient. As you can see, when I explain, I always make a draw for the patient to explain. This is implant number 3. This is implant number 4. And our plan is to place the keratinized tissue here between these two implants in order to preserve the bone. That piece of the tissue will come from the palate, from roof of the mouth. And the way I explain it to the patient is always we have this model. So we're going to say, and then, so the palatal area is this, and then we're going to borrow the tissue from the roof of the mouth, from the palate. Before we do that, we're going to scan the palate with an intraoral scanner, and then we're going to use our printer to print one of those. This is called palatal stent. So when we're removing the tissue from roof of the mouth from here, and then suturing that area, we're going to deliver the patient the palatal stent, which is this one goes up here and cover that donor side. So when we're doing this procedure for many years, the most common complaint that we have from the patient wasn't the surgical side, wasn't the recipient side. The patient always complained from the donor side, the area that we're harvesting a tissue. But since we're using the palatal stent, and also we draw blood from the patient, and then we use LPRF membrane, and we use those LPRF membrane, we put it inside that area. So that will minimize the pain and swelling. And then also on the top, we use that palatal stent. So within those years, between like 6, 7 years now, and then this is one of the most routine procedures we're doing it for the patient. I would say we do maybe 50 or 60 grafts per month, I mean, almost once or twice a day. There is no complaint. Only one time, and the patient doesn't want this or didn't wear it. So that's kind of a common sense. So the plan is to measure the area, harvest the tissue from the palate, and put it around the implant on that side. So and I make a draw for the patient. So we draw it there. So the plan is to do it. So what are the steps of that? The first step is to kind of like create a recipient site. So by creating recipient site is we have to prepare a vascular bed. So here's the common sense. If I removing piece of gum, piece of the tissue from roof of the mouth, I'm cutting the tissue there, right? I'm cutting the blood supply. When I'm taking that tissue out, putting on the recipient side, I have to reestablish that blood supply back for the tissue, and that's why we're gonna do. If you've seen on the video, why what I'm trying to do is I'm trying to create a recipient site for that tissue. So it's we're removing those epithelium. I am removing all those muscle fibers. It's a very, very gentle movement of the scalpel. By the tip of the scalpel, I'm stretching and removing all of those muscle fibers away from that area. So what I'm trying to do, I'm trying to expose the periosteum. So the periosteum is a part of the tissue that it's supplying blood to the bone. So in perio, we have a slang, and our slang is the periosteum is the skin of the bone. It's super attached to the bone. It provides blood supply to the bone, and then this is our target area. We're going to remove everything except the periosteum. So the periosteum is our blood supply. So when we're harvesting the graft, we suture the graft over the periosteum. As you can see, it's very, very important to remove all those muscle fibers. We're not going to leave anything there. We're going to remove the epithelium because that's isolation, so it should be away. And at the very, very bottom, we're going to suture whole thing to the bottom of the vestibule. So as you can see, just like all those muscle fibers, epithelium, the marginal tissue, everything sutured down so we don't let anything comes up. And then we see the vascular bed. It's reddish. It means a lot of blood there, and the bed is ready to secure and suture the free gingival graft. So as you can see in this on the photo, I put make it bigger here. As you can see it here, this is my probe. So I do the measurement for the both implants, number 3 and number 4 is about 15 millimeter of the tissue. We harvested a little bit more, and this is the size of the tissue. So for a free gingival graft, we never remove the epithelium. We leave it there. If you can see at the bottom of it, there is some kind of like a adipose tissue. There are some fat tissue is there. So we don't want any of those. I mean, it comes from the palate, the part of the palate, especially on the bicuspid area. There are some fat tissue. So before we transfer the tissue to the recipient side, we're going to remove it. You can hear here. We're going to remove the whole tissue out, make it square and perfectly placed to that area. As you can see on this video, you can see I'm transferring my harvesting tissue to the recipient side. It's transferring there. We have to make sure all the edges are matching. So we call it butt joint, like all the margins of the recipient side and margins of the graft are attaching like this, and it should be perfectly matched. If usually the graft is a little bit bigger than recipient side, so we are able to trim. So always should be, it's better to be bigger than smaller, right? Because we can cut it, we can trim it. So when we receive that, then we start suturing it. So the suturing is very important because we have to make sure the graft is 100% secure to the recipient side. So I usually start with the very thread. It's called 7.0 PGA. It's very small. You have to use magnification for it, but it's kind of give us a good kind of like a stability of the tissue. I use it on the four corners of the tissue, make sure my tissue is securely positioned in the proper area. And then I'm going to use the 6.0 glycon for the more kind of like a securing of the tissue, because we know four sutures with the thin thread 7.0 PGA is not enough. We need more secure, and then that's what we're gonna do. We're gonna use multiple, I would say 7 or 8 single sutures to secure that tissue on that area. And then this is the way we can establish a very thick keratinized tissue around the implant. And what that tissue does is it's going to be attached to the implant. It will preserve the bone, and then a patient can easily brush it. One of the most common complaint that patient has with the thin tissue around the implant is whenever they're brushing it, it hurts. And that's very common because the tissue is very thin, pushing it against the middle, and then there's kind of like a squeezing the nerve ends, and patient feels the pain. And most of the time they try to, by gently brushing it or skipping brushing it, make the situation even worse because it hurts and they cannot properly establish a good oral hygiene there. That's why when we adding that tissue there and make the tissue thicker, I mean what we call it in perio, we call it biotype conversion. We converting the thin gum to the thicker gum. The thicker gum is very stable. You brush it hard, it's not going to go away. It doesn't hurt. And then the most important part is that tissue will preserving the bone. So we will save the bone. And then when we save the bone, we can save the implant. And that's going to be the most common procedure that we do around the dental implant, which that times that the bone grafting is not possible. We add the tissue, and that tissue will save those implants. Thank you.